Good afternoon, everybody, and a warm welcome to the launch of the ADNeT Clinical Quality Registry report for 2023. I'm Henry Brodati. I am an old age psychiatrist and a researcher at the Centre for Healthy Brain Ageing at the University of New South Wales. I co-chair the ADNeT Clinical Quality Registry with Stephanie Ward, whom you'll meet soon. I'd like to start by acknowledging country, which will happen when the next slide appears. Thank you. The Australian Dementia Network acknowledges the traditional custodians of country throughout Australia and their continuing connections to land, sea, and community. We pay our respects to all Aboriginal and Torres Strait Islander peoples, their cultures, and to their elders past and present. So the ADNeT Registry is part of ADNeT, and it's supported by the Australian Government, the Department of Health and Aged Care under the National Clinical Quality Registry Program. As I said, it's part of the broader ADNeT, which is a multi-institutional, Australia-wide consortium of dementia researchers and clinicians with partners and supporters in every state. And they're shown on this slide. The key people are Stephanie Ward, the clinical lead is who she is, and Professor Susanna Ahern, who's the academic lead. The registry is managed by Monash University, and you can see all the different institutions who are partners to ADNeT on the right hand of the slide. And not mentioned on this slide are the wonderful team behind this who make it all happen. And there are a few of them, and I won't go through each individually. So here are our speakers today. The program, the first speaker will be Stephanie Ward. Stephanie wears multiple hats over that curly hair, and one of them is she is a geriatrician at Prince of Wales Hospital. She's affiliated with Monash University, and she also is affiliated with she's a senior researcher at the Centre for Healthy Brain Ageing, or CHEBA, at UNSW. She is, as I said, the clinical lead and steering committee co-chair of the ADNeT Registry, and she has been really integral to what's happening here. The other speakers will be Associate Professor Jane Alty from the Ireland Clinic, and she'll present the impact of registry participation at her clinic. So from the ground up, how is it really working? And that clinic is a participating service as part of ADNeT Registry. Following that will come Sally Lambourne. Sally's at Dementia Australia, and she'll talk about the registry's collaborative living experience engagement activities with Dementia Australia. Sally coordinates the engagement with people and with dementia and their carers. Our next speaker will be Lydia Arkos-Holzinger. Now, Lydia is from the Australian Institute for Health and Welfare, or AIHW, and she'll talk about the dementia data gap and the value of the ADNeT registry data. So many of you may not know that we've been collaborating with AIHW, and ADNeT provides a very rich source of data for them. And then the final speaker will be our academic lead, Professor Susanna Ahern, who is really the queen of clinical registries in Australia. And she's from Monash University, and she'll present the registry's plan for 2024 and beyond. Now, the next slide will show the Q&A. If you have questions, click the Q&A button and put your question in. And your questions will be answered as much as we can during the Q&A session at the end of the webinar. You can upvote, a new word for me, upvote a question by clicking the thumbs up icon, which I think means you make it more a priority. So I've already introduced Stephanie, so I'll hand over to her and she'll take over at this point.
Thank you, Henry, for that introduction. And thanks everybody for making yourselves available on this lovely Friday afternoon. It's such an honor for me to be speaking to what I know is a really broad and diverse audience on the last day of Dementia Action Week. Because we know in Australia over 400,000 people are estimated to be living with dementia. We know that it is the second leading cause of death and the leading cause of disability, disease burden for people aged over 65 years. And I know that this afternoon, I'm speaking to a lot of different people. Some people here are clinicians. Some people here are researchers. Many people have lived experience of either living with dementia, or prodromal dementia syndrome, or of caring for someone with dementia. And in Australia today, many of us are going to be touched by the experience of dementia in some way. And I think no matter where our interests lie, whether it be in prevention or research or care or experience, I think one of the commonalities that we all have is that we just want things to get better and to be able to do things better. And those initiatives, that desire really underpinned the initial Australian Dementia Network initiative, which was a broad NHMRC-funded consortium which began in 2018 and had 3 key pillars, which included accelerated screening of people to be able to participate in clinical trials. It included initiatives to support memory clinics in the delivery of best quality care through the ADNeT Memory Clinic arm with the publication of memory clinic guidelines. And the third key pillar was the establishment of the Australian Dementia Network Registry, a clinical quality registry, and we're releasing our annual report today. The Australian Dementia Network Registry is a clinical quality registry, which means that its primary purpose is collecting data that can inform us about the quality of clinical care that we deliver to people diagnosed with both dementia and/or mild cognitive impairment. And clinical quality registries have a basic structure whereby clinicians enter a brief amount of clinical data on people who meet the eligibility criteria newly diagnosed. That data is securely recorded and analysed to highlight if there's any variations between clinicians and between different sites. Every 6 months, our registry provides participating sites with a report which shows clinicians their patient profiles and practices, and really importantly, the experiences of people who come to their clinic, with the idea that actually understanding this data can help drive change. And we're already seeing the way that clinical sites across Australia are using their registry data to change practice and improve outcomes for the patients that they're treating. But registries also can give us bigger insights at a national level. And that's why our annual report is a really big milestone for us. We can look at our data across Australia and detect patterns and areas of need, particularly in this time where dementia diagnosis and treatment is poised to change with the availability in coming years of new diagnostic tools, as well as new therapeutic options. National registry data can also be very useful for government, and we'll be hearing a bit later from the Australian Institute of Health and Welfare about the ways that the ADNeT Registry data can help measure performance against the National Dementia Action Plan. So I'm going to share with you briefly some of the key findings from the 2023 ADNeT Registry annual report. This report contains data from over 60 participating clinical sites all across Australia on 1,915 new participants. By the end of 2023, we had 4,280 participants in the registry. This has been steadily growing over time. By the end of 2023, we had participating sites across most states and territories in Australia. And I am pleased to report a little spoiler for the next annual report, but we will be having additional sites, including Northern Territory, for next year. We're also pleased that we have representation from both metropolitan but also regional Australia, with nearly a third of our participating sites coming from regional Australian sites. We also have a mix of both public and private services participating. Approximately 63% of participants in our registry have been diagnosed with dementia and 37% with mild cognitive impairment. The most common subtype of dementia in the registry is Alzheimer's disease only, followed by mixed Alzheimer's and vascular dementia. The median age of diagnosis for dementia in Australia is 79 years and 76 years for people diagnosed with mild cognitive impairment. And this is really useful for us to know, particularly when we interpret studies that have been conducted in patients with dementia and looking at age ranges that were included and working out whether that's representative of the experience in Australia. Approximately 35% of participants were born outside of Australia, and nearly 10% of participants who have dementia in Australia prefer to use a language other than English at home. One of the important aspects of the registry is measuring clinical quality indicators, which give us a measure of whether we are delivering the standard of care that we set out to do. We can also look at variations between sites. One of the challenges across Australian clinical services is the ability to provide rapid access to a diagnostic service. And we can see that only 56% of clinical services are able to see a referral within 90 days. However, most other basic aspects of diagnosis are being undertaken. At the time of diagnosis of dementia, over half of people diagnosed with Alzheimer's disease subtype are prescribed a cholinesterase inhibitor. We've also been collecting data on the status of future decision-making appointments at the time of diagnosis, and importantly, how often clinicians are referring people with a diagnosis of dementia to a post-diagnostic support program, knowing how important this is. At the time of a diagnosis of dementia, 73% of people are independent in basic personal activities of daily living, such as washing and dressing, but only 20% are independent in most instrumental activities of daily living. Many people with a diagnosis of dementia are still driving at the time of their diagnosis. The registry also tells us the median cognitive test scores at the time of diagnosis of dementia, and we collect information on the MMSE, the MOCA, and the RUDAS, a cognitive screening tool validated for use in people from culturally and linguistically diverse backgrounds. We also understand that people living with dementia may have other medical issues that impact upon their care, such as the presence of neuropsychiatric symptoms such as depression, anxiety, and sleep-wake disturbance, which collectively are present in over half the people diagnosed. We understand that falls are a particularly high risk in people living with dementia, and nearly 1/3 of people diagnosed in Australia have had at least one fall in the past 12 months. We also know that a history of delirium and polypharmacy are common issues, and our registry shows that these are common issues for people in Australia diagnosed with dementia. One of the really valuable aspects of the registry is the fact that we collect information directly from patients themselves, as well as their caregivers, on both their own self-reported health and well-being and their quality of life. We also ask for experience with diagnostic services and meeting expectations. We're really excited about the impact the registry has been making, both at the local level, and I'm really pleased to be handing over to Associate Professor Jane Alty from the Island Clinic, who will be speaking to us about how she has been able to use the registry data to evaluate a new and innovative service model.
Thank you so much, Stephanie, and it's an absolute pleasure to be here today talking at this really important meeting, and thank you very much for inviting me. So I'm a neurologist, I'm a medical doctor, and I work at the hospital as well as at the university. And today I'm going to be talking about the Island Clinic, which is a statewide cognitive assessment clinic here in Tasmania. So as many of you will know, Tasmania, we have the oldest demographics of all Australian states, which is wonderful. But that does bring with it some challenges in terms of higher rates of dementia and also higher rates of dementia risk factors. And unfortunately, traditionally, there's been rather patchy access to services across Tasmania in terms of having cognitive symptoms assessed. And this has made it really hard for people to get a diagnosis if they're concerned about dementia, particularly for those people that live in rural or remote areas. As I'm sure many of you know, making the diagnosis of dementia is sometimes quite challenging. It requires seeing different specialists and having various tests. And if you don't live in one of the bigger cities, having to travel to those cities for access to those services just puts additional barriers there. So we were really mindful of the additional challenges that we were facing when designing a new clinic. And the Island Clinic is really a brand new clinic. It only opened in 2021, and we purposefully designed it with this one-stop shop model, which a lot of research and preparation went into. We visited other clinics around Australia and also in Europe to see what was working well and what might work well here in Tasmania. And if you're interested in the details, you can just see down there at the bottom left that we've published a paper outlining those details. But in short, we will see anybody across Tasmania who has at least 3 months of cognitive symptoms and is referred by their GP and not yet diagnosed with dementia. So we're very much a diagnostic clinic and strongly underpinned by research. And as you can see with these little coloured boxes, once somebody is referred, they will have an MRI brain scan, and then they will move through a series of rooms where they'll have about an hour with me or one of the geriatricians, about an hour with a neuropsychologist, and about an hour in a research room where we particularly focus on people's movements. Because as many of you will know, when people are developing cognitive symptoms, they often have problems with movement as well. They go away and have some lunch, and whilst they're having lunch, we sit together as an interdisciplinary team. We look at the MRI scans, we go through the test results, and we form what's called a consensus diagnosis. So this has been shown to be far more accurate and robust than if just one person makes that diagnosis. And then the clients come back in the afternoon and we deliver the diagnosis to them. And we're very lucky that we're also supported by Dementia Australia, who provides support workers into our clinic. So after we've talked about the diagnosis, they can move into a room to see those support workers. And of course, those that are diagnosed with dementia or mild cognitive impairment we also ask their permission to bring their data up onto the ADNeT Registry that you've just heard about. So I've just mentioned here, we're particularly interested in looking at movements in the clinic and also blood tests for developing new blood biomarkers. And it's just been great. Initially, we weren't sure if people would want to take part in research as well as coming for assessment. And nearly everyone does, and see that as a really positive aspect of the clinic. So today I'm just going to summarise what's been great about being part of the ADNeT Registry is that we have the ability to really benchmark our clinic against other clinics, look at where our strengths are, where some of the challenges are, and also just how our clinic might be different in some ways to other clinics and services that we can develop around it. And these are just the first year results. We only run the clinic 1 day a week. What was interesting for us, though, is we were tending to see a greater proportion of people with mild cognitive impairment compared to the other ADNeT sites. This is from 2021. And I think also what was really encouraging is that that one-stop model was enabling us to make that, to shorten that time from referral to diagnosis. And that was really pleasing to see. And we appreciate this clinic wouldn't be for everybody. Some people wouldn't want everything done on 1 day, but for those that did, it allowed us to give that information so much quicker. We are in the process of re-evaluating how we're performing really and how the clinic is running, and I've just put a few of those numbers here. It's interesting over time, the split across the diagnoses has changed. So when we first opened, a lot of people came that we diagnosed with subjective cognitive impairment, but actually the proportion of people that we're now diagnosing with dementia and mild cognitive impairment is growing. And I think really important for here in Tasmania, we're seeing referrals from across Tasmania, including those rural populations. So 1/3 of the people that we see in our clinic will be from those rural populations. We're also growing in terms of the number of GPs across Tasmania. Almost 2/3 of GPs now are referring to our clinic. I think it took a little while for the information to get out there. So I'll just finish up there. I hope you found that interesting, and I hope you can see some of the impact that we found from being part of the ADNeT Registry. Thank you.
I think we're now going to hear from Sally Lambourne, who is representing Dementia Australia. Thank you, Sally.
Thanks, Stephanie, and thanks everybody for coming out on a Friday afternoon. I'm coming to you from the lands of the Gadigal and Wangal people, and I pay my respects to elders past and present. I'm the General Manager of Consumer Engagement at Dementia Australia, and we've got a really important relationship with the ADNeT Registry, where we collaborate with them to ensure that the lived experience voice is heard, and people are involved in work across the ADNeT Registry in all kinds of places. So I'm going to share a little bit about what we've been doing the last couple of years with you this afternoon. So the purpose of our collaboration, as I said, we want to ensure the voice of people living with dementia and mild cognitive impairment and their carers are present, that they're heard, valued and supported. And we want them to be part of both high-level and practical solutions in regard to ADNeT systems and services. And why both ADNeT and Dementia Australia really value this and work really hard to achieve lived experience expertise is that people living with dementia and carers and living with mild cognitive impairment bring their unique expertise because of their diagnosis, because of their experiences, because of the way they have sort of in-depth knowledge of navigating systems and services. And they also have first-hand experience of stigma and discrimination. So some of the ways that people living with dementia and carers have been involved with ADNeT is that we have 3 lived experience experts on the ADNeT steering committee, Tara Quirk, Anne Peach and Gwenda Darling. We also have people involved, dementia advocates involved in the survey working group. And while that work slowed down in recent times, there was a real investment in making sure that the surveys were appropriate, accessible, that the questions could be understood. So both Scott Cooper and Jenny Fitzpatrick brought incredible lived experience knowledge to that working group. And then over the years, we've people with lived experience have been involved in a number of different things. And in the last couple of years, there's been some translation of registry documents. So this is really important, again, to make sure that you know, the documents are accessible, that the language is correct, and not just translated, but understood by people who've got a lived experience of dementia. So Mabel Cheng and Elena Donati were involved in providing feedback on invitation documents like the postcards and the posters and the survey documents, patient and carer surveys as well, and invitation letters, both in Chinese and in Italian. They've also been involved in research aspects. Mabel was involved in part of a grant application, which was unfortunately unsuccessful, but we'll keep trying. And Tara was a speaker at the ADNeT Registry Symposium at the ADRF in May in 2023. So engagement is only as good as what the people who are being engaged and involved tell us. So I asked all of the advocates who've been involved recently in working and collaborating with ADNeT how they felt and what they'd like me to share with the audience today. And these are some of the comments that came back to me. And the first one is about that there's always a pre-meeting for advocates a day or two before the meeting to run through the agenda and discuss any queries we might have. And this is really, really important. And we often do this in Dementia Australia before we run focus groups or meetings, because we want people to be able to participate equally in meetings or groups. And so to make sure that what's being presented is understood, that people are clear about meeting papers. Sometimes there's lots of papers and lots of documents to get through. So it's really important to make sure, particularly for people living with dementia, that they're across what the meeting is going to be about. They've also been involved in how graphs and tables and pictures are presented. So then that's really accessible as well. And that's both from a meeting perspective and also for documents that go out to people who may be getting a diagnosis as well. And one of the advocates said, what always impresses me about ADNeT is the consultation and inclusiveness. I always feel like my opinions and thoughts matter. Xiaoping and Casey always ensure I understand the research data that may be beyond my comprehension of stats. Another person said, I feel really valued and that the work ADNeT does is so clearly focused on people living with dementia as their priority. Another one is about the benefits that people living with dementia also get from being part. It's not just that you get a benefit, but they also get this benefit. It's understanding the information given so freely by experts in the field of dementia, like Stephanie and Henry, and their work is always so useful in assisting me with my own changes in my brain. Another response was about the confidence that that the information that's gathered to deliver best practice research ensures that data is collected and used ethically. So some really great feedback from advocates. We made a significant contribution throughout the development of the ADNeT surveys through our living experience with dementia as a person living with it and a carer. So there were two people who were sitting on the survey working group. And going forward, Dementia Australia has a pivotal role in ensuring the ongoing presence of living experience expertise and future pathways And I think that that's really important. We continue to change and evolve, and I'm always in contact with Casey and Xiaoping to make sure any work that may impact on people living with dementia and carers involves people living with dementia and carers as well. And finally, overall, a very positive experience and contribution to the development of the registry. So it's a great summary. So thank you, everyone. And I just want to acknowledge all those advocates who've been involved in the collaborative work between Dementia Australia and ADNeT.
Thank you so much, Sally. That was such a fantastic presentation. It was really lovely to hear. And so I'm now going to introduce Ms. Lilia Arkos-Holzinger from the Australian Institute of Health and Welfare. We're really from the Dementia Improvement Unit from the Population Health Group. We're really excited to be working with the Australian Institute of Health and Welfare. So I'll hand over to you, Lilia.
Thanks, Stephanie. So today I want to talk a little bit about the value of the ADNeT Registry in the face of the key dementia data gaps that we face. So for some background, at the National Centre for Monitoring Dementia, or NCMD, we undertake a range of different routine reporting of dementia statistics using available data. And we also work to improve dementia data. And this involves systematically identifying high priority data gaps and working to close them. One of the key data gaps that we have identified relates to diagnosis and management. And the main issue in this area is that there is a lack of national GP and other specialist data that have diagnostic information recorded systematically. We think that this is an area where the ADNeT Registry can add important insights for reporting dementia, as I'll illustrate through a couple of examples. So for some background, at the NCMD, we rely quite heavily on linked administrative data for reporting dementia statistics. An example of such a linked administrative data set is the National Health Data Hub, which brings together or links a range of different data, like data on medications prescribed under the PBS, hospitalization events, and aged care services. While this data is quite powerful for our routine monitoring, it does have limitations. And one of the key limitations it has is that we are still not able to tell when someone was diagnosed with dementia and how that diagnosis was delivered. To help address this gap, we are currently in the early stages of working with the ADNeT Registry team to do a one-off linkage project that will see ADNeT Registry data added to the National Health Data Hub. We think this will be a really powerful and insightful new data source because we know that with certainty that ADNeT Registry participants had a clinical diagnosis, and we also know when they received that diagnosis. So we think we're going to be able to better understand patterns of health and aged care service use, and also to know with more precision how the use of these services relate to the time of diagnosis. Another project we are undertaking in the NCMD is working, it is one that relates to the National Dementia Action Plan. Now, this plan sets out government priorities over the next 10 years with the aim of improving the lives of people with dementia, their families, and carers. And our role at the AIHW is to publish annual indicators that will help us regularly and consistently track whether the plan is meeting its objectives. Now, here you can see the 8 areas of focus of the plan. One of them relates to improving dementia diagnosis and post-diagnostic care and support. Now, while we know that the ADNeT Registry is not representative of the wide range of diagnostic experiences of people living with dementia, the data does provide us with unique information on key areas that governments want to prioritize and which we don't have access to from any other source. So, for example, one of the measures of progress of the plan is going to be whether people are receiving more timely dementia diagnosis. Now, we're going to be using ADNeT Registry data to track 2 relevant indicators. And you can see these 2 indicators here. The first tells us that 60% of people had their initial appointment with the specialist diagnostic service within 3 months of referral, and only 13% of people had a diagnosis of dementia, had their initial appointment with the specialist service within 1 year of symptom onset. So what we would like to see is that over the life of the plan, governments put in place initiatives and investments to improve timely diagnosis, and as a result, that we can see these percentages increase over the life of the plan. These are just a couple of examples of the value that we think the ADNeT Registry adds to dementia monitoring. And we are really positive that as the registry continues to grow, we're going to be able to use it even more, and it's going to become more powerful for reporting. I'll hand back now to Henry. Thank you.
Here we go. Thank you very much. That was really interesting, and it's good to see how the data is actually, leading to outcomes that will be useful for planning services in the future. It's my pleasure now to introduce Susanna Ahern. Susanna is a professor at Monash University. She's the academic lead for the ADNeT Registry. She's the head of the Clinical Outcome Data Reporting and Research Program at Monash University, and is the academic lead for 5 national quality registries, including, apart from dementia, cystic fibrosis, breast devices, pelvic floor procedures. She's currently a member of national and state-based committees regarding clinical quality registries, including the Clinical Quality Registry Framework Review Advisory Group. Well, that's not the end of it, of the Australian Commission of Safety and Quality in Healthcare, and is co-chair of the Australian Clinical Trial Alliance Registry Special Interest Group. So I'll hand you over to Susanna.
Thank you very much, Henry. And as the Monash academic lead for the ADNeT Registry, I would like to thank everyone for joining today. I've not got any slides, I'm just going to talk. And I hope you've found today's presentations insightful and inspiring. I would just like to say a few words to finish off about the future directions for the ADNeT Registry, because this is not the end of the ADNeT Registry story, it is the beginning. In terms of registry maturity, the ADNeT Registry is still a young registry. It has achieved a lot in terms of creating a community of practice and making a difference at a local clinician and health service level, but there is so much more it will do. The ADNeT Registry will be a witness to what I expect to be a transformation in care for people with mild cognitive impairment and dementia. In fact, it is more than a witness. It will be a guiding hand, supporting not only individual clinicians, but the Australian health system in monitoring and measuring outcomes from emerging novel disease-modifying therapies. This is important not only to prescribing clinicians and their patients, but also for the Therapeutic Goods Administration to ensure safety of the new treatments. The infrastructure established by the ADNeT Registry will enable any specialist practitioner anywhere in Australia who is prescribing novel treatments to enter data into the ADNeT Registry for post-marketing surveillance, whether they wish to contribute to the broader ADNeT Registry or not. Like many others, I expect that the emergence of novel treatments will lead over time to significant changes in the model of care for people with dementia. These will be active treatments and will need monitoring over the long term. I have seen in other settings the clinical transformation that can occur when new disease-modifying treatments become available that can prolong life and importantly, improve quality of life. For example, in the Cystic Fibrosis Registry, this has witnessed a significant transformation in well-being since the introduction of disease-modifying therapies in the last 6 to 7 years in Australia. However, this is not without challenges. New infrastructure and service delivery models need to be developed, and the reality of unexpected improved health can lead to unanticipated issues. As one person with cystic fibrosis put it, I have life insurance, but not superannuation, and now I'm going to live to over 60. So there will be bumps along the way, but we have a monitoring and improvement system inbuilt in the ADNeT Registry that will provide information and insights regarding how clinical care and outcomes are changing, providing regular reporting and feedback to healthcare providers to assist them. Further, the ADNeT Registry will collect longitudinal information about the trajectory of dementia that has never been possible before, providing insights into service planning needs and impact on overall population health. The ADNeT Registry is not working in isolation. As we've heard, as part of ADNeT, it joins a partnership of 21 academic, health service and other clinical organisations. The ADNeT Registry is also a member of an international community of dementia registries led by the US Alzheimer's Association called ALZNet that aims to share experience and knowledge, particularly in relation to implementation and outcomes from the new dementia treatments. But I expect that we will learn from each other much more than this alone. The ADNeT Registry is also closely aligned with the AIHW, which we've just heard, ensuring that the registry's information and insights are incorporated into national planning and policy activities. The ADNeT Registry truly has national and international support, reach, and capability. I look forward to continuing to work as part of the ADNeT Registry team towards the registry's goals of improving outcomes for people with MCI and dementia, providing contemporaneous, high-quality information for clinicians, researchers, and other key stakeholders to support their needs, and further leveraging registry infrastructure in the future to enhance and support clinical trials in dementia. Thank you again for your attendance at the launch of the ADNeT Registry 2023 annual report.
Thank you, Susanna. So that's the end of our formal presentations, and this is an opportunity now for us to open the floor up to you, our audience, and many of you are participants or supporters of the registry in some way. I already can see there's a number of questions up in our Q&A, and I'm going to direct some of these to some of the experts here and answer some of the others. There's a question here about how do clinics join the registry? Is there a cost, and do we support that process? Susanna, would you like to briefly speak to how we onboard clinics in the registry if they would like to join?
Thanks, Stephanie, and thanks. That's a great question. So we very much encourage clinics to participate. Sometimes we reach out directly to clinics, but other times we're very welcome for clinics to reach out directly to us. The main onboarding process involves an ethics and governance approval process. So likely we have ethics approval, but we'll probably need governance approval. So there's various paperwork, etc., that needs to go through a governance office, but we do most of that. The clinicians just need to provide a little bit of support at their site. And then it's also about the lead clinician talking to their team at their site and making sure that everyone's on board to participate, what's involved, training, etc. There is no cost though. It's all free and you get lots of support from the registry.
Thank you, Susanna. And a question around terminology, which comes up so often in my clinical practice, including from fellow doctors. What's the difference between dementia and Alzheimer's disease? Are they the same thing? Henry, could I ask you to briefly bring us all up to speed with that?
Sure can. I'm surprised that it's still coming up. But so just before I do, if people want to get more information about joining the registry, who do they write to, Susanna? Or Stephanie?
I think the best way to contact is through email. So I think there'll probably be email information. There'll be email information on the annual report and probably in the webinar invitation as well. There's some contact information, but or through ADNeT directly.
Right. Thank you. Yeah, dementia is a broad church. It's a umbrella term for many sorts of dementia. Over 100 have been estimated. The commonest four are Alzheimer's, vascular, frontotemporal, and Lewy body and frontotemporal in that order, or various mixed dementias. So Alzheimer's is just a type of dementia. Dementia is very simple. It's just two elements to diagnose it. The person has cognitive decline from where they used to be, and it's interfering with day-to-day function. Once you meet these two criteria that meet the syndrome of dementia, then it's the clinician's job to try and find out what the cause is. And Alzheimer's is the most common cause.
Thank you, Henry. That's a great answer. There's a question about what percentage of patients diagnosed have been diagnosed with mild cognitive impairment and mild Alzheimer's disease. I'm going to answer this one because I've recently looked it up, and just roughly about a third of our participants in the registry have a mild cognitive impairment. And of our patients who've been given a diagnosis of an Alzheimer's subtype, if we were to use a very broad way of the cutoff of an MMSE score of above 22, which is being used to define mild dementia for prescribing new medications overseas, it's just under half of our people with mild Alzheimer's disease are diagnosed at the mild stage. And what we see with our dementia diagnosis is that, around 50% of people who are diagnosed at the time of diagnosis would be more at a moderate to severe stage of disease. And I can see in the chat that the email address for the ADNeT Registry has been shared as well, which is fantastic. There's a few questions here and comments around the difficulties that happen post-diagnosis. A comment here that diagnosis isn't the hard part, it's what happens after, accessing supports for people with dementia. And there's also a question about, a really good question about whether we can look at measuring post-diagnostic care and support services, and that idea of more longitudinal follow-up. Susanna, could I throw to you to talk about the ways the registry might be evolving to look at capturing data on this, really critical part of the care pathway?
Thanks very much, Stephanie. Yes, I think it definitely has been challenging because in many instances, following a diagnosis, there's not always a structured approach to follow-up or regular clinical follow-up. And as a registry, we are designed to collect information at time points of clinical care. So if the clinical care doesn't occur, it's difficult for us to collect information about that. But what we're expecting is that with the new disease-modifying treatments, there will be greater investment and changes to the model of care such that people that are having treatments will need to be followed up regularly, and that will provide the clinical infrastructure, if you like, for the registry to start to be able to collect that information. And I hope that this follow-up doesn't just happen for people on the new treatments, but I hope that regular follow-up becomes more embedded in clinical practice just generally.
Thank you, Susanna. And a couple of questions here that a lot of people have upvoted. One is it possible for researchers to apply for access to data from the linkage to the ADNeT Registry with the National Health Data Hub for research studies? And I might ask both Susanna and Lilia to comment on that important question. I
think in the longer term, yes, we definitely want to have a resource or a repository that is available for access upon request and review by researchers. I'm not sure about the pilot project, but definitely in the longer term. Lilia, did you want to anything?
No, that's absolutely right. It's still in the very early stages, this project. So yeah, too early to tell. I will say, however, that there is a move of government institutions wanting to grant researchers access to data following, after following an approvals process. So for example, the National Health Data Hub now allows researchers to apply for access. So yeah, there's a move in that direction.
Thanks, Lilia. And a really important question about how we anticipate further growth of our registry to increase representation of clinics and people within the registry, and a concern that perhaps the clinics that are participating at the moment might be a biased sample of better clinics, and that we're not capturing all practices. And that's a really good point, and it's definitely we want to continue to grow and develop our registry. Professor Ahern, you mentioned at the beginning that we are still a relatively young Registry. And we would expect over time to continue to grow. And we are seeing growth of about 10 to 15 sites per year at this stage. And we do hope that we can get more representation. And we're quite excited by moving into new areas. And but there's definitely scope for us to continue to do that. Did anyone want to add to that?
I think I just might, say as well, Stephanie, that in primary care, a lot of them refer to the memory clinics and specialists for diagnosis, although I accept not all. But we do know that there's these new diagnostic biomarkers that are on the horizon as well. And I think one of the long-term advantages of that is that GPs can make a more confident or diagnosis of dementia with more confidence. So I think that will also change the diagnostic landscape.
Thank you. Henry, did you wish to say something?
Yeah, 2 points. One is, I guess our model's been what's happening in Sweden. And Svedem was one of the first and the most successful dementia registries in the world. And they estimate 75% of all people diagnosed with dementia, I'm not sure about MCI, are on the registry. And we've got a long way to go to get there. But as you say, as they say, you know, every journey starts with a single step. And that pathway will continue to go up as long as we have continued funding. We'll get there in the end. The other thing is that we are hopeful that we can add to the registry because the new monoclonal antibodies for the treatment of Alzheimer's disease are on the horizon. Applications are with the TGA currently, and if they are approved, it'll be essential that those people are monitored carefully. And we have an application led by Susanna and Stephanie to see if we can get funding to have a special add-on registry for those people.
Thank you, Henry. Now we're going to have to wrap up very soon, being a Friday afternoon. There's so many really great questions and things for us to think about, but I'll just get to a couple of them quickly. There's a question here about what can we tell us about the demand for diagnostic services, given that we only capture people with a diagnosis. Really good point. We can't capture information on people that never ended up with a diagnosis. I guess we indirectly do by looking at wait times between referral and first appointment. And we do see that this is across the nation, the poorest performer on quality indicators, and there's a lot of variability there. And as a registry grows, we'll get better data, the bigger data that we have. We also have let me see what else. We have a question about how quickly the data from the registry can be translated into practical benefits for those living with dementia. And I'm really pleased to say that some of our clinics have actually looked at their data and changed their processes as a result of what they were seeing. And that's the really nice part. Clinicians really want to do the best they can, but sometimes without data to actually see what you're doing, sometimes you don't quite see that perhaps your wait times are too long. Perhaps you're not referring as enough to post-diagnostic programs as you thought you were, as your gut told you were. And that's the beauty of this type of data, because it shows where there are avenues for improving. So I'd like to think that already it's helping people deliver a better quality clinical service. It's small steps, and I think that there's potential for the data to be harnessed to make bigger and more impactful changes. But it's really lovely to see and get those stories back from clinics where they've found areas for improvement and they've been able to act on it, because that's really a big part of what this is about. A comment that we don't have enough representation from Canberra. Well, we'll be there next year. Really good point. And how do we encourage people to join? We don't pay people to be part of this, and we try and make the experience of being part of the registry really worthwhile for clinicians and try and minimize the burden and keep people engaged and continue by word of mouth to encourage more clinics to join. I think that's been highlighted from a lot of the questions today. How can we make this bigger and more representative? And they're definitely areas of priority for this registry. And I think we might need to wrap up, but there's a lot of comments here about the absolute key importance of post-diagnostic support. And that's something that as clinicians, we all agree upon. And it is something really important, and the registry's ability to measure referral to and ideally uptake of would be a really important and welcome step into the future. So it's time for me to wrap this launch up. And I would just like to say, firstly, thank you to all of the panelists who've been part of the presentation today and shared your experiences with the registry data and why it's been helpful. I'd like to thank all the participants, the audience that participated today and contributed such wide and really important and insightful comments and asked us questions. This registry is an entity that belongs to all of us, with the purpose of making care and outcomes better for people at risk of or living with dementia. And it will only work if everybody puts their 2 cents in and helps us to make this better and better as time goes on. Before I finish, I really want to now acknowledge the extraordinary work of the ADNeT Registry team, led by National Program Manager Casey Wallace. I'd like to especially acknowledge Dr. Xiaoping Lin, whose hours and painstaking attention to detail has really driven the formation of this report. I'd like to thank Alan Su, our amazing state coordinators and support staff. These people are amongst the hardest working and most committed and caring people I've ever worked with, and continue to inspire me to be part of this project. Thank you for everything you have done. Thank you for helping us produce this report. I would like to commend this report to all of the participants today to have a read, learn a bit more about dementia in Australia, and we look forward to seeing you all again next